Welcome back to Not So Complicated, and today's video is going to be very long, and this is our fourth session of Study With Me First Aid USMLE Step 1. And we are tapping into systemic pathology now, since we have completed our general principles, and in systemic pathology we are doing cardiovascular system first. And let's begin without delay. This will take almost 2 hours to finish. Maybe that is just a rough estimate, and buckle up and be ready. So basically, we start from congenital heart disease. What are actually congenital heart disease? Congenital heart diseases are the distortions in the normal development of disease during the embryonic period of a fetal development, right? That are congenital heart disease, and there are right to left sounds in maximum cases. There are the signs of early cyanosis. Cyanosis means bluish discoloration of the organs or specific body parts, also known as blue babies. This happens due to congenital heart disease, and it is often diagnosed prenatally or become evident immediately after birth. Usually require urgent surgical treatment and slash or maintenance of a patent ductus arteriosus via prostaglandin therapy. PDA is patent ductus arteriosus by a prostaglandin therapy, and there are 5 T's that cause right to left sounds, and we have to remember these 5 T's. So it is truncus arteriosus, one vessel, and then transposition, which is two vessels, two switched vessels, just like transposition of great arteries, TGA. There is what happens in TGA is actually, maybe we'll talk about that later, but let's say this is heart and there are 4 chambers, right? And then there should be pulmonary trunk, and this should be pulmonary aorta, right? And the in transposition of great arteries, these two vessels get exchanged, and that causes right to left sound. And in third case, there is tricuspid atresia, whereas there is 3 vessels. And also tetralogy of Fallot. This is a very common congenital heart disease, and there are 4 different symptoms in here. We'll talk about this later. And TAPVR, which means total anomalous pulmonous venous return. So that is total anomalous pulmonary venous return, and there are 5 letters in the name. That is why it is the 50. Okay, now persistent truncus arteriosus is another congenital heart disease, and in persistent truncus arteriosus, there occurs truncus arteriosus fails to divide into pulmonary trunk and aorta due to failure of aorticopulmonary septum formation. Most patients have accompanying VSD, which is ventricular septal defect. What happens in persistent truncus arteriosus is that in developmental cases, let's say this is truncus arteriosus. This truncus arteriosus, there are cushions developed in these valves, and then they fuse in a spiral manner, right? And like these spiral manners, and they have to then detach from themselves, and in detaching they form 2 great vessels, which are pulmonary trunk and aorta. But if they are not detached, then it is also called as persistent truncus arteriosus, which is the disease right here. And this is most patients have accompanying ventricular septal defect. And then another is detransposition of great arteries. As we talked about this earlier, I have made the figure in here too. Aorta leaves right ventricle, which is anterior, and pulmonary trunk leaves left ventricle, which is posterior, and that causes separation in pulmonary separation of systemic and pulmonary circulation, right? And then in figure A, we can see that not compatible with life unless sound is present to allow mixing of blood. And example, BSD, ventricular septal defect, or patent ductus arteriosus, or patent foramen ovale. These are 3 different sounding systems in which the blood gets mixed. The oxygenated and deoxygenated blood get mixed. These are the systems. So in this case, in TGA cases, like transposition of great arteries cases, there must be a sound present to be compatible with life. And due to failure of the aorticopulmonary septum to spiral, narrow superior mediastinum cause egg on a string appearance on CXR chest X-ray. This is very high yield. we have to remember this right here. Egg on string appearance on CXR. In transposition of carotid arteries, we see egg on string appearance on chest X-ray because due to the failure of aorticopulmonary septum to spiral, right? And that causes narrow superior mediastinum. And without surgical intervention, most infants die within the first few months of life, and that is what it occurs. Here is another figure that I have made just like this. Here is the figure of the transposition of carotid arteries, and the other congenital heart disease is tricuspid atresia, and it means absence of tricuspid valve or hypoplastic right ventricle. It requires both AST and BST for viability. So in tricuspid atresia, there is both atrial septal defect and ventricular septal defect, and ECG shows hypertrophy of right atrium, tall P waves, and left ventricle, left axis deviation in the leads. So how do we recognize if there is hypertrophy of right atrium? It is the tall P waves in ECG. P waves are tall. As we already know, this is normal ECG. This is a normal ECG, and this is P wave. These P waves are very tall in the cases of tricuspid atresia. And then tetralogy of Fallot, this is the very most common congenital heart disease, and it is caused by anterior superior displacement of the infundibular septum. And the most common cause of early childhood cyanosis is pulmonary infundibular stenosis. Most important determinant for the prognosis is pulmonary infundibular stenosis. The second is right ventricular hypertrophy. Boot-shaped heart is seen in chest X-ray, just like this. You can see here, boot-shaped, right? Just like this, there is a boot-shaped heart in chest X-ray, and overriding of aorta straddles BST, receives blood from both left ventricle and right ventricle, and another is VST, that is ventricular septal defect. We have to remember this, right? So here are 4 features that we have to remember. PROBE, probe, and P means pulmonary infundibular stenosis or pulmonary stenosis, and then R for right ventricular hypertrophy, and O for overriding aorta, and B for ventricular septal defect. What happens actually is that in here I can make you a series of reactions to remember these 4 symptoms in here. So actually there is pulmonary stenosis in here, right? And this causes this increased workload in higher right ventricle, because the blood in the right ventricle is actually meant to flow in the pulmonary region, right? But there is the stenosis in pulmonary valve, so it causes it needs excessive force for right ventricle to pump the blood. So it leads to the compensatory right ventricular hypertrophy right here, and this causes overriding of aorta because these 2 vessels are in proximity. The right ventricular hypertrophy compresses this aorta, which causes the overriding of aorta. And also there becomes, because since blood has not been able to pass to the lungs, then there is volume overload in right ventricular hypertrophy, and then this volume overload will cause ventricular septal defect. We can remember like that. So what is the primary cause? The primary cause in here is pulmonary stenosis. We can remember like that. And in squatting, there is increase in SVR, decrease in right to left shunt, and it improves cyanosis. It is associated with 22q11 syndrome. So we have to remember this. This is very high yield. And also pulmonary stenosis forces right to left flow across ventricular septal defect, which causes right ventricular hypertrophy, and also known as TET spells, often caused by crying, fever, and exercise due to exacerbation of right ventricular outflow obstruction. TET spells, we have to remember that. TET spells is clinical feature of tetralogy of Fallot. And this X-ray, we have to remember this. There is boot-shaped heart. Boot-shaped heart is due to right ventricular hypertrophy. We have to remember this. And the most important factor for prognosis, determinant of prognosis, is pulmonary stenosis, because this is the one factor that is affecting all the other factors, as I have explained in this figure right here, right? And so there is total anomalous pulmonary venous return, TAPVR. This is another congenital anomaly, and in this case there are pulmonary veins drain into right heart circulation, superior vena cava, coronary sinus, etc., associated with atrial septal defect and sometimes patent ductus arteriosus to allow for right to left shunting to maintain cardiac output. So pulmonary veins drain into right heart circulation. So basically pulmonary veins should drain into well, this is the lesion in here. We have to remember just like that, right? And superior vena cava, coronary sinus, that is, it's actually pulmonary veins are meant to carry the oxygenated blood from lungs to left ventricle, right? So left side of the heart, but in total anomalous pulmonary venous return there is pulmonary veins draining into right heart circulation. And there is another anomaly in here, upstern anomaly. This is displacement of tricuspid valve leaflets downward into right ventricle, artificially atrializing the ventricle. So there is atrializing of ventricles. This is very high yield. We can say just by the amount of information in here, upstern anomaly is the atrializing of the ventricle. We have to remember just like that, and associated with tricuspid regurgitation, accessory conduction pathways, and right-sided heart failure. This is very rare, and it can be caused by lithium exposure in utero. Lithium exposure in utero generally occurs in our diuretics use, right? So that is what we have to remember in here. And the other systems, other congenital heart disease, left to right sounds. This is acyanotic at present. Left to right sounds are acyanotic at present. Acyanotic means there is no bluish discoloration of the body, which means there is no overload of deoxygenated blood. This because left to right sounds is actually that oxygenation has already occurred, because the blood is coming from left ventricles or left atrium to the right ventricles or right atrium, and these are already oxygenated by the lungs as per the anatomy, right? So that is why there is acyanotic presentation, and cyanosis may occur years later. And frequency, because left to right sounds will frequently lead to right to left sounds in long term, right? So basically frequency of these diseases is BST greater than AST greater than PDA, and right to left sounds cause early cyanosis, left to right sounds cause later cyanosis. So RL, right to left causes early cyanosis, and left to right causes later cyanosis. You can look at that. And also there is ventricular septal defect. As we talked, there are three defects in left to right sounds: PST, AST, and PDA. And there are also defects like persistent truncus arteriosus, the transposition of great arteries, and then tricuspid atresia, tetralogy of Fallot, TAPVR, and upstern anomaly. These all cause right to left sounds, but BST, AST, and PDA cause right left to right sounds. So ventricular septal defect, it is asymptomatic at birth, may manifest weeks. It is actually the hole in heart, as we talk about. This is the cause of hole in heart. Hole in heart is normally heard in a clinical scenario, right? So this is it. It may manifest weeks later or remain asymptomatic throughout life. Most smaller defects self-resolve. Larger defects, if left surgically untreated, cause increased pulmonary blood flow and left ventricular overload, which is the Eisenmenger syndrome. This is very, 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 very high yield. Eisenmenger syndrome is very high yield. We have to remember this, and it may progress to heart failure. So Eisenmenger syndrome is a complication of ventricular septal defect, right? And in atrial septal defect, there is defect in interatrial septum, or BST, it is said by its one name. and it causes systolic ejection murmur with wide fixed split S2 heart sound, and ostium secundum defects most common and usually an isolated finding. Ostium primum defects are rarer. So ostium secundum, we have to look up to the embryology for this detailed analysis for these for these lesions, and we will tap into those when we talk embryology too. Don't worry about that. We will finish each and every aspects of this first aid. And ostium primary defects are rarer and usually occur with other cardiac anomalies. The symptoms may range from none to heart failure and distinct from patent foramen ovale, which is due to failed fusion. Patent foramen ovale and atrial septal defect has difference of failed fusion. Patent foramen ovale is failed fusion, but in atrial septal defect there occurs ostium secundum defects and also ostium primum defects. So in auscultation we hear fixed split S2 murmur, right, in systolic ejection. And in atrial septal defect there is oxygen saturation, increase in right atrium, right ventricle and pulmonary artery, and it may lead to paradoxical emboli. Systemic venous emboli use ASD to bypass lungs and become systemic arterial emboli. We have to remember this, right? And in the setting of temporary sound reversal when lifting weights or in Eisenmenger syndrome, this particular term in here, lifting weights, this is very frequently seen in clinical case scenario because this is a hallmark feature in the mobilization of emboli, right? Mobilization of thrombus causing emboli. This is the hallmark feature. So we have to remember that, and it is also associated with Down syndrome. In patent ductus arteriosus, in fetal period, sound is right to left, normal. In neonatal period, decreased pulmonary vascular resistance leads to sound becomes left to right, progressive right ventricular hypertrophy and / or left ventricular hypertrophy and heart failure. This is what it occurs in patent ductus arteriosus. In it, both left to right sound and right to left sound occurs. It is associated with a continuous machine-like murmur. Remember this, there is machine-like murmur in patent ductus arteriosus, and patency is maintained by prostaglandin E synthesis and low oxygen tension. Uncorrected patent ductus arteriosus can eventually result in lead cyanosis in the lower extremities, which is also called differential cyanosis. Right here, this is the patent ductus arteriosus. There is a connection between pulmonary artery and aorta. You can look at that. And PDA is normal in utero and normally closes soon after birth. Just when we cry and have increased oxygen tension, the PDA normally closes. And we can see the figure in here, that is what it occurs. This description right here is explained by this figure. You can look at that. And in Eisenmenger syndrome, there is uncorrected left to right sound, and it will cause right to left sound. That is Eisenmenger syndrome. There is uncorrected left to right sound, like right in BSD, ASD, and PDA. So it causes increased pulmonary blood flow. There is uncorrected left to right sound. I mean, blood is transferring from this region to this region, left ventricle to right ventricle, and there is volume overload. Since there is valve that is stopping it from going to the right atrium, this volume overload will then again go to the pulmonary region, which causes increase in pulmonary blood flow, and that leads to the pathologic remodeling of vasculature, and it causes pulmonary arterial hypertension. And then right ventricle hypertrophy occurs to compensate because there is volume overload in here. The workload to be done by right ventricle is increased, and that causes right ventricular hypertrophy. And since right ventricular hypertrophy occurs, the sound becomes right to left. So initially left to right sound now transmits to right to left sound. And then when RV is greater than LV pressure, so illustration just like this, right? And it causes lead cyanosis, cloving, and polycythemia. Age of onset varies depending on size and severity of initial left to right sound. This is very high yield Eisenmenger syndrome. We have to remember this. And there is another which is called coarctation of aorta. This coarctation of aorta is also known as aortic narrowing, as you can see, aortic narrowing. And here you can see there is the aorta, right? There is the arc of aorta, and there is narrowing in here. This is narrowing. This small region in here, like a constrictor, is narrowing, and near insertion of ductus arteriosus juxtaductal, right, and associated with bicuspid aortic valve, other heart defects, and Turner syndrome. Turner syndrome is very much associated with coarctation of aorta. You have to remember that. And hypertension in upper extremities, cyanosis, claudication, coolness and weak delayed pulses, brachiofemoral delay in lower extremities with age, intercostal arteries enlarged due to collateral circulation, which causes rib notching on X-ray. We have to remember this, rib notching. So boot-shaped heart was found in tetralogy of Fallot. Egg on string appearance was in say try to recall, try to retrieve that information. Egg on string appearance is seen in transposition of great arteries. We have to remember that thing, right? So we do not have to be confused. And rib notching on X-ray is seen in coarctation of aorta. You can make a note out of this while studying this with me. And also complications include heart failure, obviously, and increased risk of cerebral hemorrhage, like in berry aneurysms, and in aortic rupture and infective endocarditis can occur. Yeah, you can see the illustration right here. This is the illustration. And then in persistent pulmonary hypertension of the newborn, if there is persistent pulmonary hypertension in the newborn, you can look at the reason. Why is that? Persistence of increased pulmonary vascular resistance after birth is the reason. So it is associated with abnormal development and postpartum adaptation of pulmonary vasculature. The risk factors include aspiration of meconium strained amniotic fluid. This is the risk factor right here. Aspiration of meconium strained amniotic fluid and neonatal pneumonia. It leads to right to left shunt through foramen ovale and ductus arteriosus, and also preductal oxygen saturation is often greater than postductal. You have to remember this. Preductal oxygen saturation is often more than postductal. And newborn presents with signs of respiratory distress, tachypnea, and often differential cyanosis in lower extremities and equal pulses. There is no delay. So congenital cardiac defect associations, you can look at that. Not only the congenital heart disease doesn't always occur without any reason, right? So BSD, PDA, ASD, tetralogy of Fallot, there is prenatal alcohol exposure or fatal alcohol syndrome. This is very important to note it down. BSD, PDA, ASD, and tetralogy of Fallot is very much common in prenatal alcohol exposure. And in congenital rubella case, there is PDA, pulmonary artery stenosis, and septal defects. And in Down syndrome, there is AVSD, BSD, and ASD. And an infant of patient with diabetes during pregnancy can cause transposition of great arteries, truncus arteriosus, tricuspid artery, atresia, and ventricular septal defect. And in Marfan syndrome, there is MBP and thoracic aortic aneurysm or dissection, atrial regurgitation too. And then prenatal lithium exposure, there can be obstruent anomaly. You have to remember that. And then in Turner syndrome, there is bicuspid aortic valve, or there are aortic coarctation or dissection. And in Williams syndrome, there is supravalvular aortic stenosis, right? There is supravalvular aortic stenosis. And in 22q11 syndromes, as we talked earlier, there is very high frequency of truncus arteriosus or tetralogy of Fallot, right? And then we can now tap into hypertension. So basically we have to remember these all associations right here. We have to remember all of these associations. We have to revise this time and again. Let's say it again. Prenatal alcohol exposure to BSD, PDA, ASD, tetralogy of Fallot, and then congenital rubella to PDA, pulmonary artery stenosis, septal defects, and Down syndrome to AVSD, BSD, and ASD, and then infant patient with diabetes during pregnancy, TGA, truncus tricuspid atresia, and then BSD. In Marfan syndrome, usually with long hands and long legs, it causes mitral valve prolapse. MBP is mitral valve prolapse, and it can cause thoracic aortic aneurysm or dissection too. Lithium exposure obstruction anomaly, Turner syndrome, bicuspid aortic valve aortic coarctation, and Williams syndrome, supravalvular aortic stenosis. In 22q11 syndromes, truncus arteriosus, or tetralogy of Fallot. And this is how we complete our congenital heart disease, and we will now go into the hypertension. So basically, what is hypertension? Hypertension is persistent systolic blood pressure greater than 130 mmHg and /or diastolic BP greater than 80 mmHg. There is JNC classification for hypertension. You can look at that too. This is that is not so important, but still you can look at that. The risk factors we all know is increased age, obesity, diabetes, physical inactivity, and high sodium diet, excess alcohol intake, tobacco smoking, family history, and incidence greatest in black, white, than Asian people. So incidence of hypertension is greatest in black population, then white population, and Asian populations. The features are 90% of hypertension is 1 degree, primary, essential, idiopathic, and related to increased cardiac output or increased total peripheral resistance. Basically, what it is blood pressure. You can say it is the multiplication of cardiac output. It is the multiplication of cardiac output and then total peripheral resistance. This is what blood pressure is as per our Ravines and Cardiovascular pathology. And then what is cardiac output? Cardiac output is then stroke volume times heart rate. So basically blood pressure is stroke volume times heart rate times TPR. So every factors that affect stroke volume or heart rate or total peripheral resistance will affect blood pressure. That is what we need to remember in the pathophysiology of this. So remaining 10% must is secondary to renal or renovascular disease cause such as fibromuscular dysplasia, characteristic string of beads appearance of renal artery. That is due to renovascular disease, and it causes secondary hypertension, string of beads appearance of renal artery. Here you can see a string of beads in the renal artery. You can see like that, and it is usually seen in adult females and atherosclerotic renal artery stenosis, primary hyperaldosteronism, and also in obstructive sleep apnea you can see hypertension. And there are two terms here, hypertensive urgency and hypertensive emergency. You have to remember the difference. So hypertensive urgency is severe hypertension without acute end organ damage. There is no acute end organ damage in hypertensive urgency, but there is evidence of acute end organ damage in hypertensive emergency, like encephalopathy, stroke, retinal hemorrhages, and exudates, papilledema. And also papilledema is basically seen in fundoscopy, and MI, and heart failure, aortic dissection, kidney injury, microangiopathic, hemolytic anemia, eclampsia. Arterioles may show fibrinoid necrosis. Arterioles can show fibrinoid necrosis too, and it predisposes. Hypertension is not only a disease, it is also a predisposing factor to many other heart related diseases like coronary artery disease, concentric left ventricular hypertrophy mediated by angiotensin 2 and endothelin, then heart failure, then atrial fibrillation, then aortic dissection or aneurysm, and stroke, and also hypertensive nephropathy or chronic kidney disease, and also retinopathy. It has a lot of spectrum of complications, so we have to manage hypertension very much importantly. So let's tap into hyperlipidemia. Hyperlipidemia is basically the condition in which the TG amount or fat or cholesterol amount in our body is increased more than normal. So the signs are xanthomas, tendinous xanthoma, and then corneal arcus. These are the signs we have to remember. So xanthomas are basically plaques or nodules composed of lipid-laden histiocytes in skin. You have to remember this. Lipid-laden histiocytes in skin. Basically, histiocytes are the macrophages of skin, and if they get lipid-laden, then they are also they manifest the disease as xanthomas, hyperlipidemia as xanthomas, especially the eyelids, which is also called xanthelasma. Xanthelasma in eyelids right here. There are xanthelasmas. Can look at that. I don't even have to demark it. There are xanthelasma. And then in tendinous xanthoma, obviously Achilles tendon is the most important tendon where there is the lipid deposition occurs. So tendinous xanthoma. And also in finger extensors is there are lipids in finger extensors, as you can see in the figure right here, and it is associated with familial hypercholesterolemia. And corneal arcus, there it is, lipid deposit in cornea, common in older adults, which is also called arcus senilis, but appears earlier in life with hypercholesterolemia. You can look at that. This you can look at that. That is corneal arcus. So let's go into the atherosclerosis. Atherosclerosis, it occurs in the presence of hypertension actually, and also a very common form of arteriosclerosis, which is hardening of arteries. There is difference between atherosclerosis and arteriosclerosis. Arteriosclerosis normally means the hardening of arteries, but atherosclerosis is the manifestation in which there are fatty build-up or cholesterol plaques in the tunica intima, which is the inner layer of blood vessels. That is what it occurs in atherosclerosis. And disease of elastic arteries, it is a disease of elastic arteries and large and medium-sized muscular arteries, right? And the most common location is abdominal aorta, followed by coronary artery, followed by popliteal artery, which is the artery in the backside of our knee, and carotid artery, then circle of Willis. We have to remember this with the mnemonic. A copycat named Willis. Nice one. You have noted down. This is very high yield. We have to remember where is the preferential deposition of cholesterol plaques. We have to remember this. A copycat named Willis. A for abdominal aorta. Copy. C for coronary artery. Then P for popliteal artery. Then again C for cat, C for carotid artery, and then W for Willis, W for circle of Willis. That is how it is the preferences. So let's go in the risk factors. There are modifiable and non-modifiable risk factors, and that is it. Risk factors are modifiable: hypertension, tobacco smoking, dyslipidemia, increased LDL or SDL, then decreased SDL. Actually, this LDL is also known as our bad cholesterol, and LDL is also known, and SDL is also known as good cholesterol, because in the presence of LDL, it increases in actually when the LDL increases, there are scavenger receptors in macrophages, right? And these scavenger receptors like SRA or SRB will then gain the fats in themselves. So macrophages get lipid laden, and that leads to the risk of atherosclerosis. That is why LDL is actually bad cholesterol, and this happens in the presence of our oxidative drugs. That is how when it occurs usually. And decrease in SDL, the basic function of SDL is to bring fat from peripheral tissues to the liver. But if the SDL is decreased, then the fat in peripheral tissue deposition gets increased, so that causes our atherosclerosis. And in non-modifiable risk factor, there is age, male sex, postmenopausal status, and family history. And in symptoms, we can say angina, claudication, but can be symptomatic. Claudication is actually the constriction of our extremities of blood vessels, just like cold or just like that, extremities of blood vessels. That is what claudication is. There is cold claudication and warm claudication. We will talk about it later. And in the progression, inflammation is important in pathogenesis. So endothelial cell dysfunction occurs first, and then macrophages and HDL accumulates. Macrophages and HDL accumulate, which form foam cell formation, and that cause fatty streaks, and that causes smooth muscle cell migration. Actually, smooth muscle cell migration can occur from inside the cell, inside the vessel, or from the outside the vessel, exogenous source or endogenous source, and they are controlled by PDGF, platelet-derived growth factor, and also FGS, fibroblast growth factor, and that cause proliferation and extracellular matrix deposition. And then it causes fibrous plaque, and that causes complex atheroma. That is how it occurs, and also it will lead to calcification in long term if there is increased on the amount of calcium content. So we can look at that in the figure. This is our normal artery, right? And there occurs endothelial dysfunction, this integrity of endothelial cells. This integrity of endothelial cells, like C-cadherin protein in here, they break down. That is when it occurs macrophages and LDL accumulation in the intima layer right here, and that will cause fatty streak in long term, and that will cause foam cells are actually macrophages with included lipids or cholesterols. If cholesterol or lipid is ingested by macrophage, that turns to the foam cells, and it is also lipid laden macrophages. That is how fatty streak forms. In with time, it will form this proliferation. There are a lot of proliferation and extracellular matrix deposition. This is our atheroma right here, atheroma or fibrous plaque right here, and it shows it looks like this in our HNE stain. We can look at that. And the complications of atherosclerosis is basically ischemia. It also causes ischemic heart disease, angina pectoris, and also myocardial infarction like this, and aneurysm formation, peripheral vascular disease, thrombosis, embolism, renovascular hypertension, coarctation of aorta, subclavian steal syndrome. These are very much common. Right, atherosclerosis is very important in the prognosis of these diseases in cardiovascular pathology. And also there is cholesterol emboli syndrome, another one which is very important. So it is actually the microembolization of cholesterol displaced from atherosclerotic plaques. So it is microembolization of cholesterol displaced from atherosclerotic plaques. You can see in large arteries, usually the aorta. Okay, can you see it? Microembolization. These are the microembolizations right here, and it results in end organ damage due to small artery emboli and an inflammatory response. So basically, cholesterol emboli syndrome is the microembolization of cholesterol displaced from atherosclerotic plaques, and that cause end organ damage due to small artery. So the examples of end organ damage and inflammatory response are livedo, reticularis, digital ischemia, blue toe syndrome, and also acute renal failure, cerebrovascular accident, and gout ischemia. We can look at that. And pulses remain palpable because larger arteries are unaffected and may follow invasive vascular procedures, angiography, angioplasty, endovascular grafting. These are the treatment. And there is arteriosclerosis. I talked about it earlier. Arteriosclerosis is the common form of arteriosclerosis. Arteriolosclerosis is common form of arteriosclerosis. It affects arteries and arterioles, small arteries and small arterioles. We have to remember arteriolosclerosis. There is two types. It is haline and hyperplastic. Basically, haline and hyperplastic. It has a specific pathology associated. Haline has basal wall thickening secondary to plasma protein leak into subendothelium in hypertension or diabetes mellitus. This is haline. You can look at that. This arrow is right here. And this is hyperplastic, onion skinning. And in severe hypertension with proliferation of smooth muscle cells, this occurs in hyperplastic. So in hypertension cases, there is onion skin thickening of the arteries, small arteries, that is also called hyperplastic arteriolosclerosis. We have to remember this is very, very, very much high yield. And there is another thing called aneurysm. What is aneurysm? It is actually the let's say this is a blood vessel right here, and then there is tearing of the walls of this blood vessel. There are 3 layers in the wall of blood vessel, right? So there is tearing. That tearing causes hematoma right here, and in the walls of blood vessel there is accumulation of blood, which is called aortic aneurysm. So this is localized pathological dilatation of aorta. Actually, yeah, this is the case of aortic aneurysm right here. And it may cause abdominal and / back pain, which is a sign of leaking, dissection, or imminent rupture. Aortic aneurysm. And in brain aneurysm, what is typical feature? There is a popping sound when you lift certain heavy amounts of load. You hear popping sound inside your brain, and that is when you know that there is aneurysm rupture, and you need to immediately rush into the hospital. And there are types of aortic aneurysm: thoracic aortic aneurysm, abdominal aortic aneurysm, and also the differences of that, which is traumatic aortic rupture, that is the complications, right? So basically, thoracic aortic aneurysm, it is associated with cystic medial degeneration. Risk factors include hypertension, bicuspid aortic valve, and connective tissue disease, example Marfan syndrome, and also associated with tertiary syphilis, obliterative endarteritis of vasa vasorum. So what is vasa vasorum actually? Vasa vasorum is that blood vessel which supplies blood vessel. Are you getting it? This is blood vessel. To function, even blood vessel needs blood, right? So these are minor blood vessels which supply to the blood vessels. These are called vasa vasorum. That is obliterative endarteritis of vasa vasorum in tertiary syphilis, also cause thoracic aortic aneurysm. Aortic root dilatation may lead to aortic valve regurgitation. You have to remember this. Aortic root dilatation may lead to aortic valve regurgitation. The another type of aortic aneurysm right here is abdominal aortic aneurysm. Since thoracic aortic aneurysm, you can look at that. This is it. And this is abdominal aortic aneurysm right here. And this is aortic arc aneurysm. And also abdominal aortic aneurysm, it is associated with transmural, all 3 layers, inflammation, and extracellular matrix degradation. And the risk factors of include tobacco smoking, which is strongest risk factor for abdominal aortic aneurysm, and this is also the most common aneurysm present, as we talked earlier. And it is in increased age, male sex, family history, there is high propensity to develop abdominal aortic aneurysm, and it may present as palpable pulsatile abdominal mass, arrows in A. You can see here, right here. This we can see pulsatile abdominal mass point to outer dilated aortic wall. Rupture may present as triad of pulsatile abdominal mass, acute abdominal or back pain, and resistant hypertension. If there is rupture, there is internal bleeding. Internal bleeding leads to the decreased intravascular blood flow, and that causes resistant hypertension. Even if you provide IV saline or try to increase the volume, it leads to the hypertension at any cost, and that is resistant hypertension. You cannot fix it only unless and until you clip that aneurysm. And it is most often infrarenal. Distribution of vasa vasorum is reduced. This figure, we talked about it earlier here. And the traumatic and aortic rupture. It is due to trauma and slash or deceleration injury. What is deceleration injury? Suppose you are in a car and suddenly your car stops by collision to other car. That is deceleration injury, and there is MBA or significant fall. That is the example, right? And it is most commonly at aortic isthmus, proximal descending aorta, just distal to origin of left subclavian artery, extramedullary widened mediastinum. That is traumatic aortic rupture. We have to remember this. And then in aortic dissection, there is the tearing of layers between our heart, tunica intima, adventitia, and media. We all know about these three layers of heart. And there is Stanford classification of aortic dissection, which there is type A Stanford and type B Stanford. We have to remember. And also there is Debicki classification. There are two classifications for aortic dissection, and one is Stanford classification, another is Debicki classification. In Stanford there are type A and type B, and in Debicki classification there is type 1, type 2, and also type 3. So aortic dissection is longitudinal intimal tearing forming a false lumen. There is false lumen right here. You can see, you can look at this. There is false lumen right here, and it is associated with hypertension, as I talked about it earlier, bicuspid aortic bulge, and inherited connective tissue disorders, example Marfan syndrome causing endarteritis of vasa vasorum. It can present with tearing, sudden onset chest pain radiating to the back, positive or negative, markedly unequal BP in both arms. So basically there is unequal BP in both arms in aortic dissection. We have to remember this. There is unequal blood pressure in both arms. That is the case of aortic dissection. You can directly think of it. And also there are other differentials, but we can think of this as a differential diagnosis. And chest X-ray shows mediastinal widening. We have to remember this. This is very high yield, and it can result in organ ischemia, embolic stroke, aortic rupture, death. And it stands for type A, which is proximal. You can look at that. This is the abdominal, this is the whole aorta, and there it is, proximal. And type B, it is distal, involves only descending aorta. Basically it involves ascending aorta in maximum cases, ascending and arc of aorta, but it involves in descending aorta. That is stand for type B. So stand for type A involves ascending aorta, as I talked earlier, and may extend to aortic arc or descending aorta, blue arrow, may result in acute aortic regurgitation or cardiac tamponade, and treatment is surgery. And in stand for B, because it's distal aorta, involves only descending aorta and below left subclavian artery. The treatment is beta blockers, then vasodilators. The treatment protocol of Stanford A is just surgery, and then Stanford B is beta blockers, then vasodilators. And now let's go to the subclavian still syndrome, right? Let me have a gulp of water. You can read at that until I have this water. You can have a break too if you need. And also let's go to the subclavian still syndrome. Basically, there is stenosis of subclavian artery proximal to the origin of vertebral artery. There is stenosis of subclavian artery, and it leads to hypoperfusion distal to the stenosis, right? Yeah, and it leads to the reversed blood flow in ipsilateral vertebral artery, and it also leads to reduced cerebral perfusion on exertion of the affected arm. That is subclavian still syndrome, and it causes arm ischemia, pain, paresthesia, but vertebrovascular insufficiency causing dizziness or vertigo, greater than 15 mmHg difference in systolic blood pressure between arms. This difference we have to remember, greater than 15 mmHg of difference in systemic blood pressure between arms. And then associated with atherosclerosis, most common cause, Takayasu arteritis, and heart surgery. So subclavian still syndrome, there is stenosis of subclavian artery, just like this, right? There is stenosis, and proximal to the origin of vertebral artery. This is the origin of vertebral artery, And then what happens, there occurs the hypoperfusion distal to the stenosis, obviously, and that causes reversed blood flow in ipsilateral or the same side artery. That causes reversed blood flow, and reduced cerebral perfusion then on exertion of affected arm occurs. That is what it occurs. That is how we finish our subclavian still syndrome. Let's go to the coronary artery disease, right? We have still a lot to go. Be patient, be patient, be patient. That is the only way we are gonna crack this. We are gonna crack our greater than 260 plus score. So coronary artery disease. Coronary artery disease include actually angina, myocardial infarction, and ischemic heart disease manifestations, coronary still syndrome, sudden cardiac death, and chronic ischemic heart disease. We'll talk about all of these right here. Okay, let's go. What is angina? Angina is actually, just in a simple words, angina is chest pain, and it is due to the ischemic myocardium. Ischemic myocardium, since every tissue of our body needs oxygen to function, right? So if there is ischemia, loss of there is ischemia, which is the reduced perfusion of the system, reduced perfusion of our blood vessels, secondary to coronary artery narrowing or spasm, and no necrosis occurs. Actually, this is what it happens. This is chest example. For example, this is chest and this is the blood vessel that supplies, and if there is spasm or obstruction in here, there is reduced blood flow, and reduced blood flow means reduced oxygen. Reduced oxygen means there is no oxygen or ATP to function, and that causes chest pain. That is what it occurs. And there are three types of chest pain: stable chest pain, unstable chest pain, and vasospastic or prinzmetal or variant chest pain. We have to remember this. And in stable chest pain, what actually happens is it is usually secondary to atherosclerosis greater than 70% occlusion, exertional chest pain in classic distribution resolving with rest or nitroglycerin. That is what it occurs. Greater than 70% is actually the hallmark for obstruction. It increases, obstruction increases, and greater than 70% occlusion is hallmark, and it causes exertional chest pain. But on rest, it gets relieved. That is stable chest pain. And in unstable chest pain, it doesn't get relieved in rest. That is what it is. Any chest pain at rest is unstable angina, and it is either due to thrombosis with incomplete coronary artery occlusion. And there are no cardiac biomarker elevation versus non-ST segment elevation MI. There is no any visuals like this. And vasospastic, formerly called prinzmetal or variant angina, it occurs at rest secondary to coronary artery spasm. So we have to notice this here: spasm, there is occlusion. So actually, vasospastic causes due to spasm of the artery, not the occlusion of the artery. We have to remember this. And also in transient ischemic ST changes on ECG. There is ischemic ST changes on ECG. And tobacco smoking is the risk factor. Triggers include cocaine, amphetamines, and then alcohol, triptans. It should be treated with calcium channel blockers, nitrates, and smoking cessation if applicable. We have to remember this, right? And myocardial infarction, this is very much important thing that we have to do. Myocardial infarction, this is a high yield, maximum asked questions in USMLE Step 1 are from myocardial infarction. In cardiovascular pathology, let's go into it. Myocardial infarction, most often it is due to acute coronary syndrome. Rupture of coronary artery atherosclerotic plaque causes acute thrombosis. And myocardial infarction can also occur with prolonged supply-demand mismatch. Supply-demand mismatch can also do. Stable angina to prolonged tachycardia, and hypotension from pneumonia causes elevated troponin, but no acute plaque rupture can occur. Even if there is no acute plaque rupture, it can cause myocardial infarction right here. So in the we can do the differences between here. The pain in stable angina is on exertion or on exercise or physical activity, mild exertion or at rest, and NSTMI in at rest, there is at rest. there is no ST elevated MI. And in troponin level, there is no elevation of troponin level, no elevation in angina, but in STMI there is elevated, and it is also elevated in STMI. And in infarction there is none, there is none, there is subendocardial infarction, there is transmural infarction. So there is subendocardial infarction and transmural infarction. This is why we can relate that there is subendocardial infarction right here, right? So it causes non-ST elevation in MI, non-ST elevation, ST, and this is transmural because entire muscle is affected. So basically contraction system is affected, which means the differences can be felt in ECG very much clearly, which is causing ST elevated MI. This is the direct relation here. Subendocardial causes non-ST elevated MI, and transmural infarct causes ST elevated MI. The ECG senses there is possible ST depression in stable angina and slash or T wave inversion. There is possible ST depression and slash or T wave inversion. ST depression and slash or T wave inversion. There is ST depression in subendocardial infarct. We have to remember these differences. There is also pathologic Q waves and ST elevation. So difference between an STMI and STEMI is subendocardial infarct and transmural infarct, and there is ST depression in an STMI. We have to remember that, right? And in ischemic heart disease manifestation, there are coronary still syndrome, sudden cardiac death, and chronic ischemic heart disease. We will talk about evolution of myocardial infarction after that, and then diagnosis of myocardial infarction is localization, obviously, and the narrow complex tachycardias, we will talk about that, and also we'll talk about heart blocks too, and then conduction blocks, we will talk about that, and then myocardial infarction complications, we will talk about each of those complications, and then acute coronary treatments, and then cardiomyopathies, we will talk about that, and then heart failure, which is very important, and then we will talk about shock, cardiac tamponade, pulsus paradoxus, syncope, infective endocarditis, then non-bacterial thrombotic endocarditis, rheumatic fever, syphilitic heart disease, Kussmaul sign myocarditis, and then cardiac tumors. And that is how we will finish our pathology session. There is still a lot to go. No, I am not losing patience because I have studied like this before, but I haven't studied like this talking out loud, wasting this much energy. I'm doing this for you, so you better subscribe. So coronary stole syndrome, it is distal to coronary stenosis. Vessels are maximally dilated at baseline to compensate for reduced blood flow. That is what it occurs right here. Coronary still syndrome, there is distal to coronary stenosis. Vessels are maximally dilated at baseline to compensate for reduced blood flow, right? That is what coronary still syndrome is. Administration of vasodilators like dipyridamole and adenosine resadenosine dilates normal vessels. That leads to decrease in hydrostatic pressure in normal coronary arteries, and that leads to blood is shunted toward well-perfused areas, and that leads to decreased flow to myocardium perfused by stenosed vessels, that is stilled. Actually, stenosed vessels are now rubbed the blood, and that causes ischemia of myocardium downstream to pathologically dilated vessels, and that is what it is, coronary still syndrome right here. So basically, administration of vasodilators dilates normal vessels, and that leads to decreased hydrostatic pressure in normal coronary arteries, and then the blood is shunted toward well-perfused areas, and that leads to decreased flow to myocardium perfused by stenosed vessels. That is how it is stilling in here. And ischemia of myocardium downstream to pathologically dilated vessels. So vasodilator stress tests rely on differential in flow to detect potential ischemia. Rarely they can cause coronary still and true ischemia. And also vasodilation of healthy vessels steals blood from stenosed vessels. That is what it is. That in one sentence, coronary still syndrome is that vasodilation of healthy vessels steals blood from stenosed vessels, which is more dangerous. Okay, which is more dangerous. And then sudden cardiac death, unexpected death due to cardiac causes within 1 hour symptom onset or within 24 hours with no cardiovascular symptoms, most commonly due to lethal ventricular arrhythmia, example ventricular fibrillation. This is the most common cause of sudden cardiac death, that is lethal ventricular arrhythmia, impairing blood flow to the brain, associated with coronary artery disease up to 70% of cases, and cardiomyopathy in hypertrophic or dilated myocarditis, coronary artery anomalies, and hereditary channelopathies, example long QT syndrome right here, Brugada syndrome, and then they can be prevented with implantable cardioverter defibrillator. So prevention occurs with implantable cardioverter defibrillator. We have to remember this, right? Now, chronic ischemic heart disease. Chronic ischemic heart disease, the progressive exertional in chronic ischemic heart disease, progressive exertional symptoms and / or development of heart failure due to chronic ischemic myocardial damage occurs. What is it? Progressive exertional symptoms and / or development of heart failure due to chronic ischemic myocardial damage. There is myocardial hibernation. Left ventricle systole dysfunction in the setting of chronic ischemia occurs. Since left ventricle systole dysfunction occurs, there is no blood pumped to our organs, and that causes our each of our organ failure. Potentially reversible with myocardial reperfusion, but there is a risk of reperfusion injury in there, and it is seen in stable angina, acute MI, or heart failure. Contrast with myocardial stunning, which is transient, reversible left ventricular systolic dysfunction after brief acute ischemia. So myocardial hibernation and myocardial stunning has two differences, right? Myocardial hibernation occurs in chronic ischemia, and stunning occurs in acute ischemia. And it is potentially reversible. It is transient and very much reversible. The myocardial stunning is transient and reversible. So evolution of myocardial infarction. This is very important, very confusing, very hard to remember thing right here. And even if you read multiple times, you will have hard time remembering this, retrieving this information. So you need to do quite a lot of revision in this portion. So, and also a lot of questions are asked in this. Evolution of myocardial infarction. Commonly occluded coronary arteries are LAD, RCA, and circumflex. These all three are the arteries of heart, and LAD is left atrial descending artery, then right circumflex artery, then circumflex artery, right? And the symptoms are diaphoresis with excessive sweating and nausea, vomiting, severe retrosternal pain in left arm and jaw, shortness of breath, and fatigue. So if somebody asks why the pain is actually transmitted to left arm and jaw in myocardial infarction, that is because the nerve that supplies heart has the same dermatome for left arm and the left jaw. So that is the reason. Let's go to the evolution. In the 0 to 24 hours of myocardial infarction, what actually occurs in gross anatomy is that there is an occluded artery and there is dark mottling, pale with tetrazolium stain. In tetrazolium stain, the bival heart muscle is looked red, right? And this is dark mottling, pale with tetrazolium stain. And in light microscopy, you can see wavy fibers up to 0 to 4 hours, and then early coagulative necrosis in 4 to 24 hours. You can see here. There are wavy fibers. These are wavy fibers right here. These are wavy fibers, and this region here is our content released to blood, edema, hemorrhage, causing coagulative necrosis. These are necrosis region. And in reperfusion injury, what actually happens is free oxygen radicals and reactive oxygen species increase, and also there is increase in calcium influx, which causes hypercontraction of myofibrils, and that cause dark eosinophilic strips. That is what reperfusion injury is. Now, what is the basic mechanism of reperfusion injury? There is increase in free radicals and reactive oxygen species due to oxygen overload in certain region, and also increased calcium influx that causes hypercontractility of myofibrils, causing dark eosinophilic stripes. And the complications of this phase right here is ventricular arrhythmia, heart failure, and cardiogenic shock. We have to remember this all. And in 1 to 3 days, what occurs is hyperemia occurs, that then extensive coagulative necrosis occurs, right? There are wavy fibers, then early coagulative necrosis. Now extensive coagulative necrosis occurs, and tissue surrounding infarct shows acute inflammation of neutrophils. So CN, coagulative necrosis plus neutrophils is there, and the complication is post-infarction fibrinous pericarditis. And in the third stage, there is 3 to 14 days, there is hyperemic border and central yellow-brown softening in gross morphology, and in microscopic histopathology there is macrophages, then granulation tissue as margins. Here you can see these are all macrophages, and these are granulation tissues right here. That is what it occurs. So basically what is happening, wavy fibers, then early coagulative necrosis, then late coagulative necrosis plus neutrophils. There is late coagulative necrosis plus neutrophils, and then coagulative necrosis plus macrophages. Then we happen to occur, there is granulation at margins, then extensive granulation, then scar formation occurs. So basically the complication of this stage right here, when granulation tissues appear at margins, is free wall rupture, and that caused cardiac tamponade. Cardiac tamponade is just like pneumothorax, but there is air in between pericardial layers, pericardium in here. And also papillary muscle rupture causes mitral regurgitation. Interventricular septal rupture due to macrophage mediated structural degradation causes left to right sound, and left ventricle pseudoaneurysm causes risk of rupture. We have to remember all of these complications. So there are a very high risk of free wall rupture, and then also papillary muscle rupture. And we can remember, or we can just conceptualize the effects of these ruptures, right? And 2 weeks to several months, there is gray white scar right here, and it causes contracted scar complete, just like this. You can look at that. And the complication here is post-cardiac injury syndrome, heart failure, arrhythmias, true ventricular aneurysm, risk of mitral thrombosis there. That is how the evolution of myocardial infarction occurs. So how do we diagnose myocardial infarction? There are a lot of markers for diagnosis of myocardial infarction, and in the first 6 hours ECG is the gold standard, right? In the first 6 hours ECG is the gold standard, and the cardiac troponin I rises after 4 hours. Cardiac troponin I rises after 4 hours, peaks at 24-hour, and is increased for 7 to 10 days. It is more specific than other protein markers. So troponin I right here is more specific than other protein markers. And CKMB, creatine kinase MB, increases after 6 to 12 hours, peaks at 16 to 14 hours, and is predominantly found in myocardium, but can also be released from skeletal muscle. So there can be dilemma right here, because since it can also be released from skeletal muscle, there is non-specificity more attached to this cardiac marker than cardiac troponin I. It is useful in diagnosing reinfarction following acute MI. In diagnosing a reinfarction following acute MI, because levels return to normal after 48 hours. And ECG changes can conclude ST elevation if it is transmural infarct, and ST depression if it is non-STMI or subendocardial infarct, right? And hyperacute peak T waves, T wave inversion pathology, Q wave, or poor R wave progression evolving or old transmural infarct is the ECG finding. That is how it occurs in ECG. Here you can see the ECG localization of STEMI. If there is infarct location is in endoreceptal region, that is LAD, the leads with ST segment elevations or Q waves are B1, B2. Then anteroapical, that is distal LAD, the lead is B3, B4. Anterolateral, that is LAD or LCX, that is B5, B6. And in lateral, LCX, that is in AVL, and in inferior RCA, lead 2, 3 and AVF, and in posterior PDA, lead is B7 to B9, ST depression in B1, B3 with tall R waves. So this is very much high yield. This information right here provides us, if the question gives you ECG and ST segment elevation in specific leads like this, then you can recognize which artery is actually being affected in this myocardial infarction cases. So if it is enteroceptal, there is B1, B2. If there is B3, V4 lead ST segment elevation, it is distal LAD. And if there is B5, B6, it is LAD or LCX. And in I and AVL lead, it is LCX. In 2, 3 and AVF lead, it is RCA. And in B7 to B9, it is PDA. You can look at these all leads here in ECG. So now narrow complex tachycardias. We will tap into narrow complex tachycardias. Narrow QRS complex, less than 120 millisecond rapid ventricular activation by a normal ventricular conduction system. Tachycardia originates within or above AV node, which is also called supraventricular arrhythmia or paroxysmal supraventricular arrhythmia. That is what it occurs, narrow complex tachycardias. In arrhythmias, there are atrial fibrillation, multifocal atrial tachycardia, then atrial flutter, and paroxysmal supraventricular tachycardia. And also Wolff-Parkinson-White syndrome. This is my personal favorite disease from cardiovascular pathology, Wolff-Parkinson-White syndrome. Now, I even have personal favorite disease, right? It's so weird. And also in atrial fibrillation, there is irregular rate and rhythm with no discrete P waves. And arrhythmogenic activity usually originates from automatic foci near pulmonary vein, ostia, and left atrium. Common risk factors include hypertension, coronary artery disease, advanced age, and atrial dilation. It may predispose to thromboembolic events due to left atrial blood stasis, particularly stroke, and then LA appendage is the most common site for thrombus formation and atrial fibrillation. LA appendage, we have to remember this. Left atrial appendage is the most common site of thrombus formation and atrial fibrillation. The management of atrial fibrillation involves rate and rhythm control using beta blockers, calcium channel blockers, and digoxin and cardioversion, ABCD. So we have to remember like this. There is irregular baseline absent P waves because there is atrial fibrillation right here. RR1 is not equals to RR2, not equal to RR3, not equal to RR4. A, for atrial fibrillation, we have to manage rate and rhythm via B for beta blockers, C for calcium channel blockers, and then D for digoxin, and C again, which is cardioversion. If it is not possible to manage by any medications, we have to do by the cardioversion. And in multifocal atrial tachycardia, there is irregular rate and rhythm with at least 3 distinct P wave morphologies due to multiple ectopic foci in arteria. There is, you can see, P wave, 3 different P wave morphologies are there, 3 different regions. There is a tall P wave, there is small P wave, There is distorted P wave, there is normal P wave. There are three different P wave morphologies, and this is due to multiple ectopic foci in atria. It is associated with underlying heart conditions or conditions such as COPD, pneumonia, and heart failure. And in atrial flutter, there is rapid succession of identical consecutive atrial depolarization waves. Rapid succession. There is sawtooth appearance in P waves. This is very much high yield. In atrial flutter, there is sawtooth appearance in P waves. You can look at this. These all are P waves. Sawtooth appearance. Right? 4:1. The ratio of sawtooth appearance 4:1. That is a lot. And arrhythmogenic activity usually originates from re-entry circuit around tricuspid annulus, and it should be treated like atrial fibrillation plus minus catheter ablation region between tricuspid annulus and also inferior vena cava. Another narrow complex tachycardia right here is paroxysmal supraventricular tachycardia, and most often due to reentrant tract between atrium and ventricle, most commonly in AV node. What actually happens is, for example, this is AV node, and this is a wave. This gets distributed to this, and then travel down the ventricles, right? This is what it occurs in the conduction system in normal regions. But in paroxysmal supraventricular tachycardia, what happens is there is fibrosis in here. And since the waves should have been directed like this, what happens is they travel back. They travel back and back and back and back and back like a feedback loop, and this causes supraventricular tachycardia, paroxysmal tachycardia, and it commonly presents with sudden onset palpitations, lightheadedness, diaphoresis, and it terminates by slowing AV nodal conduction, vagal maneuvers, and adenosine. This is the treatment right here. AV nodal conduction, vagal maneuvers, and adenosine. Definitively treat with catheter ablation. That is how we treat. And there is Wolff-Parkinson-White syndrome right here. It is the most common type of ventricular pre-excitation syndrome. It is the most common type of ventricular pre-excitation syndrome, and an abnormal fast accessory conduction pathway from atria to ventricle, this is bundle of Kent, bypasses rate slowing AV node, and ventricles partially depolarize earlier, which leads to characteristic delta wave with widened QRS complex and shortened PR interval, and it may result in re-entry circuit causing supraventricular tachycardia. This is what Wolff-Parkinson-White syndrome is. There is re-entrant tachycardia right here. This is the re-entrant circuit, and this causes supraventricular tachycardia. This is orthodromic re-entrant tachycardia, and this is antidromic AV re-entrant tachycardia. And the treatment of Wolff-Parkinson-White syndrome is procainamide, ebutilide, and we have to avoid AV nodal blocking drugs like adenosine, calcium channel blockers, and beta blockers. There we can see delta wave, there is retrograde P wave, and there is again delta wave and wide QRS, and there is also P R interval decreased in here. You can look at that. So that is Wolff-Parkinson-White syndrome, and there are wide complex tachycardias. We talked about narrow complex tachycardias right now, and they included atrial fibrillation, multifocal atrial tachycardia, atrial flutter, paroxysmal supraventricular tachycardia, and Wolff-Parkinson-White syndrome. And in wide complex tachycardias, there are wide QRS complex greater than 120 millisecond. So a slow ventricular activation outside normal ventricular conduction system, and tachycardia originates below AV node ventricular arrhythmia. And in arrhythmia, we have ventricular tachycardia, torsilis de pointis. It sounds like an Italian disease like. I'm so sorry, I have a broken humor. And also, in ventricular tachycardia, there is typically regular rhythm. Rate is greater than 100, most commonly due to structural heart disease like cardiomyopathy, scarring after myocardial infarction. There is ventricular tachycardia, and it has high risk of sudden cardiac death. As we talked earlier, the highest risk of sudden cardiac death is tachycardia right here, most commonly due to lethal ventricular arrhythmia, which is ventricular fibrillation. We talked about it, right? And then there is Torsades de Pointes. It is polymorphic ventricular tachycardia, like this. You can see here. Sorry. Like this, you can see here, right here. This is polymorphic, and it causes shifting sinusoidal waveforms. There are waveforms in here. Sinusoidal, that even sinusoidal waveforms. That is Torsades de Pointes, and it may progress to ventricular fibrillation. There is long QT interval. Example, sinus bradycardia, congenital long QT syndromes predisposes to Torsades de Pointes, and it is caused by drugs, decreased potassium, decreased magnesium, and decreased calcium. Torsades de Pointes, the literal meaning of it is twisting of points, and we can see in ECG that there is also twisting of points, and it is causing sinusoidal waves right here. And the treatment of Torsades de Pointes is defibrillation for unstable patients and magnesium sulfate for stable patients. In unstable patients, we have to defibrillate, and in stable patients, we have to give magnesium sulfate. Drug-induced long QT. There is mnemonics. There are drugs that induce long QT or Torsades de Pointes. We have to remember this. A, B, C, D, E, F plus N, O. A for antiarrhythmics. A for antiarrhythmics type A, IA and type III, and then arsenic 2. B for antibiotics, macrolides and fluoroquinolones. C for antipsychotics, that is haloperidol and chloroquine. D for antidepressants, TCAs, and then diuretics. And E for antiemetics, ondansetron. F for antifungals, fluconazole, and NO. N for Navir, protease inhibitor, and then O for opioids, which include methadone. So A for antiarrhythmic drugs, IA and III, and also arsenic. B for antibiotics like macrolides and fluoroquinolones, and C for antipsychotics like haloperidol and chloroquine disease, and also chloroquine drug, and D for antidepressants, TCAs, and also diuretics. E for antiemetics like ondansetron, and then F for antifungals like fluconazole, and N for Navir, which is protease inhibitor, and then opioids, which is methadone. Drugs inducing long QT is A, B, C, D, E, F plus NO. That is our mnemonics. And there is in ventricular fibrillation, there is disorganized rhythm with no identifiable waves, just like this. There is no discernible rhythm in here, and the treatment is fatal without immediate CPR and defibrillation. And also we can go into the hereditary channelopathies right here. Hereditary channelopathies, which is Brugada syndrome, which includes it, and also congenital long QT syndrome, as we mentioned it earlier, and also sick sinus syndrome. Let's go into the in hereditary channelopathies, there is inherited mutations of cardiac ion channels, and it leads to abnormal myocardial action potential, and also it leads to increased risk of ventricular tachyarrhythmias and sudden cardiac death. SCD is sudden cardiac death. And for example, Brugada syndrome. In Brugada syndrome, what actually happens, it is a autosomal dominant disease, and most commonly due to loss of function mutation of sodium channels. But it is loss of function mutation of sodium channels. In Brugada syndrome, there is loss of function mutation of sodium channels, and there is increased prevalence in Asian males. This pattern of pseudo-right bundle branch block is seen, and ST segment elevations in lead B1, B2 are also seen. ST segment elevation in lead B1, B2 is also seen. It prevents SCD with ICD. And also congenital long QT syndrome, this is most commonly due to loss of function mutation of potassium channels affects depolarization. Here it affected depolarization, Here it affects repolarization, congenital long QT syndrome. Okay, it includes Romano-Ward syndrome and Zerville and Lang-Nielsen syndrome. Romano-Ward syndrome and Zerville and Lang-Nielsen syndrome. So Romano-Ward syndrome is autosomal dominant, pure cardiac phenotype. There is no deafness. And Zerville and Lang-Nielsen syndrome, there is autosomal recessive and sensory neural deafness. So this is congenital long QT syndrome. So there are two different hereditary channelopathies. Brugada syndrome, congenital long syndrome. Brugada syndrome, there is congenital dysfunction or loss of function mutation of sodium channels, and in congenital long QT syndrome, there is loss of function mutation of potassium channels affecting repolarization. And it includes Romano-Ward syndrome and Zerville-Lange-Nielsen syndrome. And in 6 sinus syndrome, there is age-related degeneration of facet node. Sinus, SA means sinoarterial node. So sinus node is sick in here because there is congenital or age-related degeneration, and ECG can show bradycardia, sinus pauses. There is no P wave in here, delayed P waves. There can be sinus arrests, dropped P waves, and also junctional escape beats. P waves can either be delayed or be dropped, can show bradycardia and then sinus pauses and also junctional escape beats. That is 6 sinus syndrome. Let me have another gulp of water. My throat is drying up. And we'll go into the conduction blocks. You can pause the video and have a break. It's a long night, no? I'm filming this video in night and it's already midnight. So in conduction blocks, there are degrees of blocks. There is first degree AB block, then second degree AB block, Mobius type 1, wink back, then second degree AB block, Mobius type 2, and third degree complete AB block, and also bundle branch block. Bundle branch block also includes right bundle branch block. I'm mumbling. Right bundle branch block and left bundle branch block. So in first degree AV block, there is prolonged PR interval greater than 200 millisecond, and the treatment, there is no treatment required in benign and asymptomatic. It is very benign and asymptomatic. You can look at this ECG findings in here. And in second degree AV block, Mobius type 1 is also called wink back block. It leads to progressive lengthening of PR interval until a beat is dropped. What happens is PR interval in here is smaller, and then it becomes bigger, and then it becomes more bigger, and P wave is absent, and there is also absent QRS. So actually in second degree AV block, Mobius type 1, there is progressive lengthening of PR wave until a beat is dropped down. So P wave not followed by QRS complex, which is dropped. The literal meaning of dropped is there is a P wave, but there is no QRS complex. It has variable RR interval with a pattern regularly irregular pattern. Treatment non-required, it is usually asymptomatic. And in second degree AV block, Mobius type 2, there are dropped beats that are not preceded by change in PR interval. The PR interval is equal, but there is dropped beats absent QRS, and there is P wave preceding P wave, but there are no change in PR interval earlier. And in Mobius type 1, there is changes in PR interval. We have a treatment, usually a pacemaker in here, and it also indicates a structural abnormality such as ischemia or fibrosis. And in third degree complete AV block, P waves and QRS complexes rhythmically are dissociated. Atria and ventricles beat independently of each other. Atrial rate is usually greater than ventricular rate. You can see here, right here, and it may be caused by Lyme disease. Lyme disease, here is mnemonic, E is reversed to 3, right? In Lyme disease, treatment is pacemaker again. And in bundle branch block, there is interruption of conduction of normal left or right bundle branches, Affected ventricle depolarizes via slower myocyte to myocyte conduction from the unaffected ventricle, which depolarizes via the faster His-Parkinson's system. So basically, it is commonly due to degenerative changes like cardiomyopathy and infiltrative diseases. Here is a classic example of left bundle branch block in B1 and B6 leads. And there we can go into the premature beats. There are premature atrial contraction and then premature ventricular contraction. We have to remember these two because these are also high yield. Let's go. So premature atrial contraction, there are extra beats arising from ectopic foci in atria instead of SA node. There are extra beats arising from the ectopic foci in atria, right? A red arrow is showing here, and it is often secondary to increased adrenergic drive. It is often secondary to increased adrenergic drive due to caffeine consumption, obviously, and benign but may increase risk for atrial fibrillation and flutter. It may increase risk for atrial fibrillation and flutter. And there are narrow QRS complex with preceding P wave and ECG. You can see here there is narrow QRS complex. And in premature ventricular contraction, there are ectopic beats arising from ventricles instead of SA node. Instead of SA node, beats are arising from ventricles. That is why it is called premature ventricular contraction. The shortened diastolic filling time, there is decreased stroke volume compared to normal beat. And the prognosis is largely influenced by underlying heart disease. Wide QRS complex with no preceding wave on ECG is seen. But there is narrow QRS complex with preceding P wave in ECG. So there is distinguishing feature in premature arterial contraction and premature ventricular contraction, right? So there are complications of myocardial infarction. This is cardiac arrhythmia at first. It is in first few days to several months. It can be supraventricular arrhythmias. Ventricular arrhythmias are conduction blocks. Notes: due to myocardial death and scarring, important cause of death before reaching the hospital and within the first 48 hours post-MI. Within the first 48 hours post-MI, we can limit this complication. And also peri-infarction pericarditis. In 1 to 3 days, pleuritic chest pain is the findings. Pericardial friction rub is hard on. You can remember this. Pericardial friction rub is hard on auscultation. ECG changes. A small pericardial effusion. It is usually self-limited. Papillary muscle rupture. This is very serious case causing regurgitation of bulbs. Usually acute mitral regurgitation leading to cardiogenic shock and severe pulmonary edema. It is posteromedial greater than anterolateral papillary muscle rupture. The propensity of papillary muscle rupture is more in posteromedial than anterolateral. So as the posteromedial has single artery blood supply, posterior descending artery, whereas anterior lateral has dual LAD and LCX. This is what it is. And also interventricular septal rupture can cause shunt. There is shunting. Symptoms can range from mild to severe cardiogenic shock and pulmonary edema, macrophage mediated degradation, PST, increased oxygen saturation, and increased pressure in right ventricles. It usually occurs in 3 to 5 days. There is ventricular pseudoaneurysm. It occurs in 3 to 14 days. It may be asymptomatic. Symptoms may include chest pain, murmur, arrhythmia, syncope, heart failure, and embolus from mural thrombus. Rupture leads to cardiac tamponade, filling of air in the pericardial heart layers, and the free wall rupture contained by adherent pericardium or scar tissue does not contain endocardium or myocardium. It more likely to rupture than true aneurysm. So ventricular free wall rupture. If the ventricle free wall is ruptured, it usually ruptures in 5 to 14 days. It leads to cardiac tamponade and internal hemorrhage, which is often fatal. Left ventricular hypertrophy and previous MI protect against free wall rupture. This is protective function. Okay. 2. Ventricular aneurysm. 2 weeks to several months. Symptoms similar to pseudoaneurysm. There is outward walls with contraction, that is dyskinesia associated with fibrosis. And also post-cardiac third injury syndrome. Weeks to several months. It causes pericarditis due to autoimmune reaction. It is also called Dressler syndrome. This is very high yield. You have to remember this. Dressler syndrome is high yield. It is post-cardiac injury syndrome. It is pericarditis due to autoimmune reaction. Cardiac antigens released after injury lead to deposition of immune complexes in pericardium, leading to inflammation, which is Dressler syndrome. You can look at these figures here. It is a pseudoaneurysm here. You can look, and there is ventricular aneurysm here, and also mitral valve rupture, papillary muscle rupture in here. There is left ventricular hypertrophy, but there is free wall rupture in here. And acute coronary syndrome treatments, there is unstable NSTMI, anticoagulation, example heparin is given, antiplatelet therapy like aspirin, high dose aspirin 370 or 350 mg is given, plus ADP receptor inhibitors like clopidogrel, and also beta blockers, ACE inhibitors, statin, symptom control with nitroglycerin plus minus morphine. And in STEMI, in addition to above, reperfusion therapy is the most important, but we have to be cautious to limit the reperfusion injury in here. Percutaneous coronary intervention preferred over fibrinolysis, and if right ventricle affected, then we have to support venous return or preload to maintain cardiac output via IV fluids or avoiding nitroglycerin. Let's go into the cardiomyopathies. These are of different types: dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive or infiltrative cardiomyopathy. Okay, so in cardiac myopathy, first let's go to the dilated cardiomyopathy. Most common cardiomyopathy is dilated cardiomyopathy, which is in over 90% of cases. Often idiopathic or familial, example due to mutation of TT enzyme encoding the sarcomeric protein titin. You have to remember this, right? And also other etiologies include drugs, example alcohol, cocaine, doxorubicin, infection, Coxsackie B virus. We have to remember this Coxsackie virus right here. Coxsackie B virus, Chagas disease, and then ischemia in coronary artery disease, systemic conditions, hemochromatosis, sarcoidosis, thyrotoxicosis, wet beriberi, and peripartum cardiomyopathy. These all cause dilated cardiomyopathy, and the findings are heart failure. S3 heart sound is heard, which is also called gallop rhythm, and also systolic regurgitant murmur, dilated heart on echocardiogram, and balloon appearance of heart on chest X-ray. There is balloon appearance of heart in chest X-ray. We have to remember this. The treatment is sodium restriction, ACE inhibitors, angiotensin receptor blockers, beta blockers, sacubitril diuretics, mineralocorticoids, receptor blockers, and ICD, and also heart transplant. Notes in here is that it causes systolic dysfunction. Actually, it causes systolic dysfunction. It displays eccentric hypertrophy. You can see here, eccentric hypertrophy, because the sarcomeres are added in series. Adding in series means this is one sarcomere and another sarcomere is added in this kind of series. This is eccentric hypertrophy. But in hypertensive heart disease, there is concentric hypertrophy, because sarcomeres are added like onion skin fashion. That is the difference, right? And it is compared with two athletes' heart, where left ventricle and right ventricle enlargement facilitates stroke volume increment and also cardiac output increment. Stress cardiomyopathy, also called Takotsubo cardiomyopathy or broken heart syndrome. There it is, broken heart syndrome. Oh my god. It leads to ventricular apical ballooning, likely due to increased sympathetic stimulation, example stressful situations, right? So that is it about dilated cardiac myopathy. And then hypertrophic cardiomyopathy, it is 60 to 70% of cases are familial, autosomal dominant, most commonly due to mutations in genes including sarcomere proteins such as myosin binding protein C and beta myosin heavy chains. So myosin binding protein C and beta myosin heavy chain. It causes syncope during exercise and may lead to sudden death. Example, in young athletes due to ventricular arrhythmia, the findings are S4 heart sound, systolic murmur is heard. Then it may see mitral regurgitation due to impaired mitral valve closure. The treatment are use of beta blockers or non-dihydropyridine calcium channel blockers, verapamil, and in some cases suggestion of high intensity athletics, ICD if high risk, and also uh, avoid drugs that decrease preload. Example, diuretics or vasodilators should be given, right? And in the notes there is diastolic dysfunction ensues. So basically, in dilated cardiomyopathy, there is systolic dysfunction, but in hypertrophic cardiomyopathies, there is diastolic dysfunction because there is no enough space to have the blood accumulation, right? So ICD, basically, if you are confused about ICD is implantable cardioverter defibrillator. I talked about it earlier, but it is just in the abbreviated form. So ICD is implantable cardioverter defibrillator, right? And it displays ventricular concentric hypertrophy. As I talked earlier, this is concentric hypertrophy and this is eccentric hypertrophy. There it is in series, there it is in parallel addition of sarcomeres, and it does often causes septal predominance. Here it is. There is a large septum here, and it is fibrillar disarray and fibrosis, classified as hypertrophic obstructive cardiomyopathy when left ventricle outflow tract is obstructed, right? And asymmetric septal hypertrophy and systolic anterior motion of mitral valve or outflow obstruction, two dyspnea and possible syncope. This is the pathophysiology right here. And in restrictive or infiltrative cardiomyopathy, there is post-radiation fibrosis, low-floor endocarditis, endocardial fibroelastosis, thick fibroelastic tissue in endocardium of young children, amyloidosis, sarcoidosis, hemochromatosis. That is, please help. The mnemonics is please help. Also, okay, let's revise a broken heart syndrome right here. Stress cardiomyopathy, also called Takotsubo cardiomyopathy, broken heart syndrome. It is usually ventricular apical ballooning. Ventricular apical ballooning, likely due to increased sympathetic stimulation in stressful situations. That is broken heart syndrome. Okay. And this is the mnemonics for restrictive and infiltrative cardiomyopathy, which is please help. P for post-radiation fibrosis. Infiltrative cardiomyopathy occurs in these diseases, which is post-radiation fibrosis, Loeffler endocarditis. E for endocardial fibroelastosis, and A for amyloidosis, S for sarcoidosis, and HELP, S for hemochromatosis. There is diastolic dysfunction. So only systolic dysfunction is in dilated cardiomyopathy, and in all other cardiomyopathy there is diastolic dysfunction. It can have low voltage ECG despite thick myocardium, especially in amyloidosis, and also Loeffler endocarditis associated with hypereosinophilic syndrome. Histology shows eosinophilic infiltrates and myocardium right here. So let's go into the heart failure. There is right-sided and left-sided heart failure, and also high output and low output heart failure. There are other infective diseases that we have to tap into, right? So just maybe 4 pages more. We are left with 4 pages more. So in heart failure, what happens is clinical syndrome of cardiac pump dysfunction occurs, and it leads to congestion and low perfusion. Basically, heart cannot pump, and it leads to congestion and low perfusion of the tissues. The symptoms obviously include dyspnea, orthopnea, fatigue. Signs include S3 heart sound, rails, jugular venous distension, pitting edema. Pitting edema is just like this. There is pits when we release the pressure of hands. They're from the pits. That is what it is called, pitting edema. Then in orthopnea, I want to clarify you about this concept. A person is sleeping here in a bed, for example, and the person has a very difficulty in breathing, dyspnea during sleeping in supine position. This is because these abdominal contents right here will push the diaphragm to the cranial displacement region. So basically this diaphragm will compress the lungs, and that causes more severe dyspnea. That is orthopnea. That is occasional feature of heart failure or heart disease. We have to remember this about orthopnea. And also systolic dysfunction, it is systolic dysfunction, and there can be diastolic dysfunction too. Systolic dysfunction, heart failure with reduced ejection fraction, increased EDV, and also decreased the EDV is the end diastolic volume, and decreased contractility, often secondary to ischemia or MI or dilated cardiomyopathy occurs. And in diastolic dysfunction, there is heart failure with preserved ejection fraction. There is decreased compliance of end diastolic pressure. Increased in diastolic pressure, often secondary to myocardial hypertrophy occurs, right? That is how it occurs. Diastolic dysfunction. Right heart failure most often results from the left heart failure. This is the most important thing. The one or two times it is asked in NEET PG also, and in PLAB also. It is also asked in PLAB and USMLE. Right heart failure. The most common cause of right heart failure is left heart failure. And then carpulmonary refers to isolated right heart failure due to pulmonary cause. And ACE inhibitors, ARBs, angiotensin receptors, neprilysin inhibitors, beta blockers accept in acute decompensated heart failure, and aldosterone receptor antagonists decrease mortality in our in our heart failure with reduced ejection fraction condition. And loop and thiazide diuretics are used mainly for symptomatic relief because there is congestion, right? So there is volume overload. And hydrolyzine with nitrate therapy and SGL2 inhibitors improve both symptoms and mortality in select patients. Left heart failure, there is orthopnea. I described about it. Shortness of breath when supine position, increased venous return from redistribution of blood, immediate gravity effect exacerbates pulmonary vascular congestion. And in paroxysmal nocturnal dyspnea, this is PND, it is breathless awakening from sleep. That is paroxysmal nocturnal dyspnea. There is difference between orthopnea and PND, and it is due to increased venous return from redistribution of blood, reabsorption of peripheral edema occurs. Pulmonary edema, it is increased pulmonary venous pressure, leads to pulmonary venous distension and transudation of fluid. That leads to pulmonary edema. And presence of hemosiderin-laden macrophages, which is also called heart failure cells in lungs. So basically, heart failure has hemosiderin-laden macrophages. This is very, very high yield. Hemosiderin-laden macrophages, heart failure cells in lungs, right? And in right heart failure, congestive hepatomegaly is a symptom, jugular venous distension and peripheral edema is a symptom. Increased central venous pressure leads to increased resistance to portal flow, rarely leads to cardiac cirrhosis, which is called also cardiac cirrhosis. You can see here, congestive hepatomegaly is also called cardiac cirrhosis, associated with nutmeg liver, motile appearance and gross exam. Nutmeg liver, it is associated with nutmeg liver, right? Jugular venous tension due to increased venous pressure, peripheral edema due to increased venous pressure leading to fluid transudation. So here it is graph, decreased contractility, volume, and decreased compliance in is also seen in there. So there are this is the mechanism how drugs will work, and also the compensatory mechanism of heart failure. There it is. You can look at that. This is very, very common. And also there is high output failure, uncommon from heart failure, characterized by increased cardiac output. So high output heart failure there is increase in cardiac output. Actually, there are high output status due to decreased SVR from either vasodilation or arteriovenous shunting. It includes the causes like severe obesity, advanced cirrhosis, right? And then also severe anemia, hyperthyroidism, weight beriberi, and Paget's disease of bone. It presents with symptoms and signs of pulmonary or systemic venous congestion. So high output state is due to decreased SVR. SVR means systemic vascular resistance. Do not get confused with that. It is systemic vascular resistance. And what is shock? Let's go into the shock. Shock is actually inadequate organ perfusion and delivery of nutrients necessary for normal tissues and cellular function. Initially, it may be reversible but life-threatening if it is not treated promptly. So there are basically four types of important shocks. These are hypovolemic shock, and then cardiogenic shock, obstructive shock, and then distributive shock. Basically, it is caused by reduced volume, which is hemorrhage, dehydration, burns. In burns, there is the evaporation of fluid, right? And it is the mechanism is volume depletion. There is CBP decreased, PCWP is also decreased, cardiac output is also decreased, systemic vascular resistance is increased, and SvO2, systemic vascular oxygen saturation, is increased, right? And then in cardiogenic shock, the causes are MI, heart failure, valvular dysfunction, arrhythmia. Mechanism is left heart dysfunction. It will cause cold and clammy hands. Clammy means there are cold sweat droplets in there. Reddish hands are there. CBP is central venous pressure is increased, and PCWP is also increased in here, which is pulmonary capillary waist pressure, and cardiac output is decreased, and SVR is increased, SpO2 is decreased. In obstructive shock, the causes are pulmonary embolism, tension pneumothorax, and also cardiac tamponade. They cause impeded cardiopulmonary blood flow. So increased CBP, increased PCWP, which is pulmonary capillary waist pressure again, and decreased cardiac output, and also increased SVR, decreased SpO2. And in distributive shocks, there is sepsis, RD, and also anaphylaxis, CNS injury. It causes systemic vasodilation, and the hand is warm and dry. We have to distinguish these two. In cardiogenic shock, the hands are cold and clammy, and in distributive shock, the hands are warm and dry. We can see all the parameters in here like this. And there is also CNS injury in distributive shock, right? So basically, what is cardiac tamponade? As we talked earlier, it is compression of the heart by fluid. Example, blood or effusions leading to decreased cardiac output. Equilibration of diastolic pressures in all chamber occurs, and the findings are Beck triad, which is hypotension, distended neck veins, and distant heart sound. So we have to remember this. Beck triad. The classic feature of cardiac tamponade is Beck. I'm writing this because writing this will help us retrieve the information, even if we read it, even if we try to remember, or even if we got the concept, we have to write it down to remember and retain it. So basically, Beck triad is a feature of cardiac tamponade, and it includes hypotension, distended neck pains, and distant heart sounds. And there is increased heart rate, pulsus paradoxus is also present. And then ECG may show low voltage QRS or electrical alternance, which is due to swinging moment of heart and large effusion. Swinging moment of heart. There is swinging moment of heart. We'll talk about this in physiology. And echocardiogram shows pericardial effusion in figure, as we can see here. And systolic RA collapse, diastolic RB collapse, and IVC plethora we can see in here. Treatment is pericardiocentesis or surgical drainage. What is pulsus paradoxus? Pulsus paradoxus is actually decrease in amplitude of systolic BP by greater than 10 mmHg during inspiration. This is pulsus paradoxus. And then increased venous return during inspiration will lead to increased RV filling, which lead to interventricular septum bows towards LV due to decreased pericardial compliance, and that will lead to decreased LV ejection volume, and that will lead to decreased systolic blood pressure. Seen in constrictive pericarditis, obstructive pulmonary disease like croup, OSA, asthma, COPD, cardiac tamponade. So PCOT, pericarditis, then obstructive pulmonary disease, and croup, OSA, OSA, asthma, and then cardiac tamponade. Okay, well, that is it. Group COPD. So pulsus paradoxes are seen in P for P coat, in P coat, P for constrictive pericarditis, C for COPD, and C for group, O for OSA, A for asthma, and then T for cardiac tamponade. And there is another term called syncope. What is syncope? Syncope is actually the transient loss of consciousness caused by period of decreased cerebral blood flow. That is syncope. The types are reflex syncope is most common, which is most common. Reflex syncope is most common due to vasovagal or prodromal symptoms. Example, warmth, pallor, nausea, and episodes are sought with rapid recovery. There is situational. Example, coughing, sneezing, swallowing, defecation, micturition, and carotid sinus hypersensitivity. Example, wearing tight collar. And orthostatic syncope is there, and also cardiac syncope is there. Orthostatic is due to hypovolemia, drugs, autoimmune, autonomic dysfunction, and orthostatic hypertension is defined as a drop in systolic blood pressure greater than 20 mmHg. There should be drop. Not every drop in blood pressure is orthostatic syncope or hypertension. It should be greater than 20 mmHg in systolic, and also in diastolic there should be greater than 10 mmHg within 3 minutes of standing. There is time limit too, that there is within 3 minutes of standing. That is only orthostatic hypertension. And cardiac is arrhythmias and structural, which is seen aortic stenosis and also hypertrophic cardiomyopathy. So there is there is infective endocarditis here, which is also inflammation. And let's go to that. So infection of the endocardial surface of the heart, typically involving greater than one heart valve, is infective endocarditis. It is caused by bacteria greater than fungus. So etiology, it is the most common form is bacteria. And also in acute, there is classically Staphylococcus aureus, high virulence factor, large destructive vegetations, as we can see in the figure. These are the vegetations right here. And then on previously normal valves, there is rapid onset. And in subacute cases, classically very dense streptococci is observed in low virulence stage, and smaller vegetations and congenitally abnormal or diseased valves. So sequela of dental procedures. This is very important. If a patient presents with this history of dental procedures, there is a high likely that the case is of cardiovascular system if it includes any other symptoms, and it has a gradual onset. It presents with fever, which is most common, new murmur, vascular and immunologic phenomena. There is a criteria for this diagnosis. And also vascular phenomena includes septic embolism, pedicei, splinter hemorrhages, which is also called linear hemorrhages, lesions in nail bed, as seen in here. These are linear hemorrhages in nail bed, they are called splinter hemorrhages. This is a vascular phenomena for infective endocarditis. And Genway lesions are there, which is painless, flat erythematous lesions in palms and sole. These are Genway lesions. And immunologic phenomenon, that is immune complex deposition, glomerulonephritis, ossular nodules, which is painful, ouchy, or for ouchy, painful, ossular nodules. Then raised bilious lesions on finger or toe pads. And there are also Roth spots and retinal hemorrhage lesions, Roth spots. So in retinal hemorrhages, there are Roth spots seen. We can look at that too, and there are Roth spots right here. And also mitral valve is the most common valve that gets affected. Then aortic valve and tricuspid valve involvement is associated with injection drug use. Don't try drugs. Common associations are prosthetic valves, GI or GU procedures. GI is gastrointestinal, GU is genitourinary, and colon cancer in S. galolyticus. Then gram negative like Hassek organisms. This is very high yield. hassic organisms. So even if we forgot every other bacteria causing infective endocarditis, we do not forget this hassic organism, which are Haemophilus, aggregativector, formerly Actinobacillus, then Cardiobacterium, Echinella, and Kingella. And in culture negative cases, Coxella and then Bartonella. Injection drug use, there is Staphylococcus aureus, Pseudomonas, and Candida. The pathogenesis is endothelial injury leading to formation of vegetations consisting of platelets, fibrin, and microbes in the heart pulse, which leads to valvular regurgitation, septic embolism, systemic circulation left-sided endocarditis, and also pulmonary in right-sided. Diagnosis requires multiple blood cultures and echocardiography. There is also non-bacterial thrombotic endocarditis. There is also called Liebman-Sachs endocarditis in this setting in here. This is very important. Liebman-Sachs endocarditis. So non-bacterial thrombotic endocarditis usually happens because there is also called meningitic endocarditis. The term non-bacterial thrombotic endocarditis are also called meningitic endocarditis. Rare, non-infective. The vegetations typically arise in mitral or aortic bulb and consist of sterile platelet-rich thrombi that dislodge easily. So basically, this is the sterile platelet-rich thrombi. So usually asymptomatic until embolism occurs, associated with hypercoagulable state seen in advanced malignancy, especially pancreatic adenocarcinoma or SLE, called Liebman-Sachs endocarditis in this setting. So Liebman-Sachs endocarditis. If there is non-bacterial thrombotic endocarditis in SLE, it is called Liebman-Sachs endocarditis. There is another disease called rheumatic fever. It is a non-suppurative consequence of pharyngeal infection with group A beta hemolytic streptococci. So let's equally include rheumatic heart disease, which affects heart pulse, mitral greater than aortic greater than tricuspids. There is MAT, MA, high pressure valves affected most. So where there is very high pressure, that valves are affected mostly. So rheumatic, rheumatic. So M for mitral, A for aortic, T for tricuspid. MAT is the preference because pressure valves are affected like that. And early valvular regurgitation, late valvular stenosis are seen associated with the Escoff bodies, granuloma with giant cells, Escoff bodies in here, and in infective carditis there are Osler nodules, and its cause cells, large macrophages with ovoid wavy rod-like nucleus. These are also called caterpillar cells, and increase in anti-streptolizin O and anti-DNase beta titers also lead to the rheumatic fever. Immune-mediated type 2 hypersensitivity reaction, not a direct effect of bacteria. Antibodies to M protein, this is the pathogenesis right here. Antibodies to the M protein cross-react with self-antigens, often myosin, causing molecular mimicry. This is the high-yield USMLE equation causing molecular mimicry, and it leads to the treatment or prophylaxis is penicillin. The criteria here for diagnosis is Jones criteria. The major criteria is J for joint migratory polyarthritis, and O, which looks like heart in here, is pancreatitis. N for nodules in skin, subcutaneous, obviously, Osler nodules. And then E for erythema marginatum, evanescent rash with ring margin. And S for Sydenham chorea, which is involuntary irregular movements of limbs and face. There is another infective disease, that is syphilitic heart disease right here. And in syphilitic heart disease, we can see tertiary syphilis disturbs the vasa vasorum of aorta with consequent atrophy of basal wall and dilatation of aorta and valve ring, causing inarteritis of vasa vasorum, as we talked about it earlier. It may see calcification of aortic root, ascending aortic arch, and thoracic aorta. It leads to tree-bark appearance of aorta. Okay, what is the appearance? It is tree-bark appearance. So syphilitic heart disease shows tree-bark appearance of aorta. It can result in aneurysm of ascending aorta or aortic arc and aortic insufficiency. Acute pericarditis is another system, and other inflammation of pericardium, red arrows like this here, just like this here, you can see. and it commonly presents with sharp pain aggravated by inspiration. This is the characteristic feature. It is aggravated by inspiration and relieved by sitting up and leaning forward. In leaning forward and calling up, there is acute pancreatitis that is also get relieved, and often complicated by pericardial effusion. Between LO, there is the collection of fluid in between pericardial layers, which is pericardial effusion, and it presents with friction rub. Friction rub is hard on auscultation, and ECG changes include widespread diffuse STI segment elevation and / PR depression. Usually idiopathic, but may be due to viral infections, causing Coxsackie virus is the most common virus or infectious pathology to cause acute pericarditis. And malignancy and metastasis can cause this cardiac surgery, thoracic radiotherapy early, and MI, example, post-cardiac injury syndrome, and autoimmune disease. Post-cardiac injury syndrome, what did we call about this? This is also called WIS syndrome. This is also called DRESSLER, Dressler syndrome. Okay, the treatment is NSAIDs, colchicine, glucocorticoids, dialysis, and uremia. There is another disease here, which is constrictive pericarditis. This is chronic inflammation of pericardium. Pericardial fibrosis or classification may or may not be present, and it will lead to the limited space for expansion, and it will decrease ventricular filling, usually idiopathic, but may be due to viral infections, cardiac surgery, thoracic radiotherapy. And these all are similar idiopathogenesis in here, and TB is the most common cause in resource limited countries. Okay, constrictive pericarditis, TB is the most common cause in resource limited societies or countries. Decrease in end-diastolic volume will lead to decrease in cardiac output, decrease in venous rhythm, presence with dyspnea, peripheral edema, jugular venous distension, Kussmaul sign, pulsus paradoxus, and pericardial block. Let's talk about Kussmaul sign right here. Kussmaul sign is actually, what is Kussmaul sign? Kussmaul sign is actually paradoxical increase in jugular venous pressure and inspiration. Normally, inspiration will lead to negative intrathoracic pressure, and it will lead to increased venous rhythm, which will lead to decreased jugular venous pressure. But in Kussmaul sign, there is paradoxical increase in jugular venous pressure and inspiration, and it is due to impaired right ventricular filling. Right ventricle cannot accommodate increased venous rhythm during inspiration, and that will lead to blood backs up in vena cava and Kussmaul sign right here. It may be seen with constrictive pericarditis, restrictive cardiomyopathy, right heart failure, and massive pulmonary embolism, right atrial or ventricular tumors. Anything that impairs right ventricular filling will show Kussmaul sign. Okay. There is another inflammation right here, which is myocarditis, and myocarditis, so inflammation of myocardium, obviously, and the major cause of sudden cardiac death in adults less than 40 years old is myocarditis. Okay, major cause of sudden cardiac death in adults less than 40 years of old is myocarditis, and the presentation is highly variable. Can include dyspnea, chest pain, fever, arrhythmias, persistent tachycardia out of proportion to fever is characteristic. The multiple causes are viral, parasitic, bacteria, toxins, rheumatic fever, drugs, and autoimmune. In autoimmune, there is Kawasaki disease, sarcoidosis, SLE, polymyositis, dermatomyositis also there. So complications include sudden cardiac death, arrhythmias, heart block, dilated cardiomyopathy, heart failure, mural thrombus with systemic emboli. There is another disease here, which is hereditary hemorrhagic telangiectasia. It is also called Osler-Weaver-Rendu syndrome, which is hereditary hemorrhagic telangiectasia, also called Osler-Weaver-Rendu syndrome, autosomal dominant disorder of blood vessels. The findings are blanching lesions. Example, tongue telangiectasia. This is tongue telangiectasia right here. And also on his skin, mucous membranes, recurrent epistaxis, which is bleeding from nose, and then artery venous malformations in brain, lung, and liver, and also GI bleeding and hematuria can be seen. So what are the artery venous malformation that shows this that is shown in this syndrome, Osler-Weaver-induced syndrome. This is abnormal high flow connection between artery and vein, and also increased risk of high output cardiac failure. The most common cause of intracranial hemorrhage in children is this arteriovenous malformation. Okay, the cardiac tumors not commonly appear, but when they appear, they are usually myxomas, and their most common cardiac tumor is a metastasis, because there is no primary cardiac tumor present usually. And in myxomas, most common for primary cardiac tumor in adults is myxoma, and 90% occur in atria, mostly left atrium, and myxomas are usually described as a ball valve obstruction. Bulb valve obstruction. If anybody tells you about bulb valve obstruction, it is a myxoma and a primary cardiac tumor of heart. Cardiac tumor, it means heart, right? Yes. And it is normally lodged in left atrium with multiple syncopal episodes. Interleukin 6 production by tumor will lead to constitutional symptoms. Example, fever, weight loss, may occult tumor plop sound. There is tumor plop sound and it mimics mitral stenosis there. And in histology, there is gelatinous material, myxoma cells immersed in glycosaminoglycans, and adults make 6 mixed rings. That is what it is. Actually, the mnemonics it is. Adults make 6 mixed rings. So 6 is interleukin 6, and adults, it is most common in adults, and mixed is myxoma. So adults make 6 mixed rings. And there is another tumor which is rhabdomyomas. It is most frequent primary cardiac tumor in children. So in adult it is myxoma, and in children it is rhabdomyoma associated with tuberous sclerosis, and histology shows hematomous growth, and it is more common in the ventricles. It is more common in atrium, it is more common in ventricle. And that is how we finish our systemic cardiovascular pathology in these much hours. And it was a long run. Thank you for staying with me if you are still here, and subscribe for our next episodes, because I have been doing for you and for me. This is a great motivation for both of us. I am your study partner right here, motivated one, and we will someday achieve 260 plus in our step 1 USMLE. Yes, we will do that, obviously. And thank you so much. We will I don't know which topic we will do in our systemic pathology series, but whichever we will do, we will finish it in one long run. Even if it takes 3 hours, 4 hours, we will finish it. Thank you so much for watching, and also subscribe.